So today we do the pluck. I changed the schedule around a little bit this morning. Chris had nothing serious. It was his first appointment, and I wanted to go with him because he would just tell the doctor everything was fine. And I wanted to make sure I got the referral that I could get, and my husband doesn't have a medical background to know what to ask for. So that was at 9:45 this morning, which is why I was running late. And so what I did with them was just cancel lab. We're going to do our sheet pluck on Thursday and move the quiz, the same quiz we would have had today, till Thursday. So with you guys, we're going to go ahead and do the sheet pluck, all right? But I will move the quiz as well, all right? So it'll be we were supposed to have a separate quiz that included histology, but it'll just be the quiz that we normally would have had today because they didn't have the lab time to have the extra study time on histology. So we'll work on that today and Thursday. For you guys, they'll do it on Thursday along with their sheet pluck component, and then we'll work that in sometime so that you either have a fake quiz or sometime that you can get that material and visualize what it would be like. So today, lab will be the sheet pluck, and then the histology or review for additional anatomy. This is really our second anatomy lab. Okay, questions?
So then the quiz on Thursday will include the histology
No.
portion of the list?
That will be the quiz that I wrote for today, or
So it's
put together for today. So we'll not include the histology. It's the structures of the pharynx and the respiratory pathway and the larynx and cartilages and muscle and parts of the lung, but not histology. But I'll get somehow on the tube so you won't be unpracticed on that. We'll have some opportunity for that. Okay? So today we're looking at the first component of gas exchange, which is you'll see a little bit later. There are three aspects to gas exchange. And the first one that we're looking at today are the movements of gas in and out of the lungs, which is known as pulmonary ventilation. All right? So to be able to get oxygen into the blood or carbon dioxide away from the blood, out of the blood, we have to move the gases in and out of the lungs. And that's what pulmonary ventilation is. All right? So it's the movement of gases. And the primary gases we're talking about, of course, are carbon dioxide and oxygen. From alveoli back to atmosphere, or from atmospheric air to the alveoli. Okay, so between those two regions. Basically what we think of is breathing, okay? That's pulmonary ventilation. It involves the movement of air. And how did we describe, or how did I describe what causes our blood flow, our circulation of blood? What's the underlying factor that causes blood to flow? Pressure, exactly, pressure gradient. Okay, so blood flows from high pressure to low pressure. Air does exactly the same thing. So the movement of air molecules, whether we're talking about oxygen or carbon dioxide, is a movement from high pressure to low pressure. Now the heart pump creates the high pressure that causes cardiovascular movement. All right? We don't create a high pressure that allows air to move into the lungs. We create a low pressure. And the atmospheric pressure then pushes the air into our lungs. We don't suck it in. We create a low pressure, and the atmospheric pressure pushes that into our lungs. And then by making the lung volume smaller, we push air back out again. All right, so air itself is moving from high to low pressure. So the muscle structure, where we kind of left Thursday's lecture on page 36, talks about the muscles of inspiration and expiration that create this change in lung volume. So the purpose of all this is very basic, simple physics. If we have a given volume and we expand that volume of say a cubic foot of gas, we expand that volume without changing temperature, what's going to happen to the internal pressure of the gas? It's going to decrease. What do I mean by the pressure of a gas? Sometimes that's a hurdle that students have difficulty moving on in discussion of respiratory physiology is the concept of a gas pressure. So what do you visualize when you think of a gas pressure?
The molecules hitting the walls of the
Okay, so the molecules of gas, be they oxygen or nitrogen or carbon dioxide, hitting each other as well as hitting the walls of the chamber, all right? And that exerts a force. So the more molecules they are, or the faster they move, is going to affect the pressure. Now, by increasing the volume of our container, we're not changing the number, but we're decreasing the relative concentration. So there's fewer particles of gas within a given space. Therefore, they're less likely to hit each other and less likely from that to bounce off and hit the sides of the container. That then means that there's a less amount of pressure, right? So the gas pressure is not just by itself an isolated value due to the number of gas particles. It's also related to the volume that the gas is contained within and temperature. So what happens to movement of particles when we increase temperature?
Movement increases.
Movement increases, so pressure increases, all right? That's why a balloon will pop, as the temperature warms up. Now, consequently, however, we can actually contain more oxygen in a fluid when that fluid is colder, okay? So we can dissolve more gas particles in water as we decrease the temperature, because as the particles move around more, they're going to start coming out of solution. So we have to consider solubility as well when we're talking about gas in a solution, okay? We'll pick that discussion up on Thursday. So if we expand our volume, we still have the same number of gas particles, then pressure decreases. So there's an inverse relationship, similar to the inverse relationship between the diameter of our blood vessel and the pressure of the blood. So as we increase volume, we decrease the gas pressure, right? And as we decrease volume, we increase the pressure, assuming that temperature and everything else is the same. So we're going to look at the first factor of pulmonary ventilation as how do we then create this movement? How do we then change this pressure? And this is the factor by which we do this, all right? Rather than changing the temperature of the air or changing the that we're breathing in or breathing out. So we have changed the cavity that our lungs are contained in is the thoracic cavity. And then attached to the wall of the thoracic cavity, we have the pleura. And the pleura is also attached to the lungs. All right, so as the lungs move out, as the wall moves out and moves the pleura, it's also going to pull on the lung tissue. And that also, not just physically with the surface tension, okay, but also by changing the pressure surrounding the lungs itself. So this is a model of the thoracic wall. The pleura is included, all right, just the pressure chamber. And the plastic represents our rib cage, more rigid. It's not going to move. The diaphragm is represented by this membrane, okay, and attached to the rubber stopper. We've got a short little trachea and two bronchi, and then the alveoli are represented by the balloons. All right, now I can just blow directly into the balloons and force air into them. Or we can do it more in the fashion in which our lungs work, and that's by decreasing the pressure around the balloons and allowing the atmospheric pressure to be pushed in. So we're not talking about much of a change in pressure, just a few millimeters. So this is open, all right? That would be your nose, your external nares, if you will, allowing or you're open now. And so now if I pull down the diaphragm, all right, lowering, notice how the lungs expand, or the alveoli expand. So I've decreased pressure by expanding the volume, all right? So the pressure, the same amount, I haven't opened up the space, I allowed air, so that's equilibrating with the atmospheric air, but by decreasing, increasing the volume, I've decreased the pressure. So your diaphragm is lowered. Now when you relax and you breathe out, the diaphragm raises, decreases the volume. That increases the pressure around the lungs and causes the alveoli to collapse and pushes air out of the lungs. All right? So when we move to a higher altitude, where there's lower pressure, what's the cause of difficulty in getting our red blood cells oxygenated? Do we have to breathe harder because of this difference in pressure? We have to create a greater difference? Or is there another reason why it's more difficult, we get more tired at a higher altitude?
Is it because the pressure at higher altitude is lower?
It is, but how would that affect anything that I've done here specifically? Is that the critical cause?
Going to not fill up the lungs as fast?
Okay, we only need to decrease the pressure within the lungs 1 to 2 millimeters below atmospheric pressure to have air move into the lungs. All right? So keep that in mind. We'll come back to it before I finish with lecture today. I just want you to think about that. The reason I brought that up is I had a discussion with a student that I used to give a lift to here, and a conversation that he said, the way he was taught from his high school biology instructor, on the relevance of how this works. So I'll come back to that, just kind of think about it. So let's look at the muscles that are affecting the change of the thoracic volume and thus the thoracic pressure. So we have two different steps, breathing in and breathing out. All right? So respiration is both of those activities. So we're going to look at breathing in first. All right? That's identified as inspiration. So would you expect the thoracic cavity to be increased in volume during inspiration or decreased? Increase. Is that because air is pushing into the lungs and increasing its size?
No.
Good. That was the beginning of the conversation with the student. They've been taught in high school that your lungs increase in diameter because air is pushing into the lungs and pushing them bigger. And when you climb up, go around 7,000 or 10,000 feet in altitude, it's harder to breathe because there's less pressure to force your lungs out. And that's completely backwards, okay? So we increase the lung in size in order to cause the decrease in pressure for the airflow to move into. So we have two sets of primary muscles involved in normal as inspiration, all right? External intercostals. So are these muscles directed, if you guys remember from your muscles class, are these fibers directed in this direction, hands in the pocket, or in the reverse? Which ones are externals and which ones are internals? Hands in the pockets are external, okay? So what you can think of doing is pulling, doing exercises. So you're pulling on a stretch. So the purpose of the external intercostals in inspiration is to lift the ribs up. So they're angled in this direction and they're doing this, okay? So they're gonna be pulling the ribs up. So if we look at, this is not anywhere near anatomical correctness. I'm bringing my ribs all the way to the sternum without the costal joint. And origin is from the, I'm not going to test you on origin insertion, I'm just describing it because this is how it works. Origin is from the inferior border of the upper rib, so inferior border of superior rib. And insertion is superior border of inferior rib. So direction of contraction is that direction, right? We can see the external intercostal. We can see the internal intercostals because they don't come quite as far to the sternum, so let me leave some room for them. Okay? So external intercostals come in that direction. They lift the ribs up. So their function, well, the innervation is just intercostal nerves. And those are T2 through T12. The first thoracic spinal nerve goes to the arm, upper limb, all right? And function is to elevate the ribs, thus increasing the superior, thus increasing the anterior, posterior diameter. So it's often described as a handle of a pail that's hanging down on the side of the pail. And as the handle is lifted up, it goes away from the side of the pail, all right? So as you visualize the ribs being lifted up, they go away from the vertical, and that's going to increase the distance between anterior and posterior, all right? They don't move much, all right? So there's not much of a change in that anterior-posterior diameter. A greater change occurs with the diaphragm. The second set of muscles that are involved with inspiration then is the diaphragm. Innervated by the phrenic nerve. And it has its origin off of the lower ribs and then rises as a high dome to insert not on a bone, all right, but on a kind of almost an hourglass shaped band of connective tissue, the central tendon, right in the middle. So when the diaphragm contracts, it depresses, all right? And when it relaxes, it rises back up. So contraction of the diaphragm is going to, this lowers the diaphragm and increases the superior-inferior diameter.
The phrenic nerve? Or
The contraction of the diaphragm lowers the diaphragm and increases superior-inferior diameter. So what we're seeing, if we were to look at the thoracic cavity as a cylinder, all right, then the two sets of muscles together are going to cause a change, thus that we would have an increase in the diameter of the thoracic cavity in this fashion, and an increase in the volume in superior to inferior, okay? So this increase would be the external intercostals. And this change would be the diaphragm. So we have our increase in volume and thus our decrease in pressure. Now at times, we find ourselves requiring an extra change, an extra degree of increase in volume. So if we are up at 7,000 or 10,000 feet elevation and we're finding ourselves breathing more deeply, it is not because it's harder to get air to move into the lungs, but it's because each milliliter of air that we breathe in has less oxygen in it. Therefore, we need to take a deeper breath to get an adequate number of gas particles. Does that make sense? All right? So it's not the pressure itself that's not moving air into the lung, it's the fact that each volume of air that we take in has insufficient numbers of gas particles, and therefore we need a greater volume to adequately saturate our red blood cells, our hemoglobin, with oxygen. So we use accessory inspiratory muscles. Yes?
So technically, if there's less oxygen molecules, there's less pressure?
Yes.
Okay.
But that's not the fact that there's less pressure. In other words, we're not having to work harder to breathe because there's less, we have to create a greater difference to move air in. It's that we have to take a greater volume of air. So it's not because there's less pressure externally, which there is, to move the air in. There'd be less pressure internally too. So if you've ever taken a bottle of water up the mountain, okay, and then bring it back down. You can see it collapse as you're driving back down from Tahoe, or even Shingle Springs. And the increase in air pressure as you drive down the hill causes that plastic bottle to be compressed. All right, so if you're up, you've driven up the hill, the air that's already in your lungs is also going to be at lower pressure, in addition to the atmospheric pressure. So it's not that there's a greater difficulty in creating a gradient between the two, it's that the air you take in, because it's at lower pressure, the reason it's at lower pressure means that it has fewer gas molecules. Therefore, you need a greater volume to get adequate amount of oxygen into your lungs. Okay? And we'll look at that more detail on Thursday. So, but to create that greater volume, if I want to, let's say that I have to, instead of taking a normal breath of 500 mils, I need 1,000 mils. I'm going to have to pull down farther on my diaphragm for that to happen, okay? Or pull up more on my ribs. So our accessory muscles are not for the diaphragm, but aid the ribs. It's really difficult we don't use anything that helps to move the diaphragm down, except maybe create a lower pressure in our abdominal cavity, and that's difficult. So our accessory muscles of inspiration are to lift the ribs up more. You'll see people straining at their neck if they're sick and they're struggling to breathe. It's muscles within the neck that see strain. So accessory muscles for inspiration are muscles that, except for the scalenes, typically function to move some other part of the body. All right, they have an origin on the ribs or the sternum and an insertion on the neck or on the scapula or on the head, and we change that. So one muscle, for example, is the sternocleidomastoid. Normally, this muscle has its origin, as is in the name, on the sternum and the clavicle. Insertion is on the mastoid process, and this muscle functions to turn the head from side to side or to flex the cervical vertebra. If we want instead to lift up the sternum and the clavicle, we have to stabilize that joint, use muscles in the back of our neck to keep the head from coming down. Now when we contract that, we can pull up the sternum and clavicle. Otherwise, we would just pull our neck forward. So we have to activate stabilizing muscles on the opposite side of the joint for that to leave the head stable and not move. Another muscle is the pectoralis minor. This muscle normally has its origin on the ribs, 3 and 4 and 5, and attached to the coracoid process of the scapula. You don't have to know these processes, but you do need to be able to identify these muscles. And so they normally pull the scapula forward like this. If I want to elevate my ribs, I'm going to have to activate my rhomboideus and other muscles of my scapula to keep it from being pulled forward. Okay? And then the scapula will stay stable and the ribs will be elevated. So we flip origin and insertion. A similar muscle is the serratus anterior that normally has its origin on the ribs and inserts on the scapula. And we stabilize the scapula and use the serratus anterior. That's the one that you can see on the red torso. It looks like ribs coming down. The muscles insert normally have their origin onto each rib, but for respiration would insert onto each rib just under the armpit. You can see that's why it has the name serrated anterior. All right, and that helps to elevate the ribs. The last set are ones you probably didn't hear of in Bio 430, called the scalenes. And these normally function in respiration, for accessory respiration. They come off the cervical vertebra and insert onto the first rib and to the clavicle. And here's the sternocleidomastoid, and it's there's 3 of them right here. The nerves into your arm, the brachial plexus, pass between them. And so sometimes if they're swollen, they can cause a compression of the brachial plexus. But those are the scalenes right there. Okay. The clavicle and the first rib. All right, so here you're just seeing a little bit of them right here. Here's the sternocleidomastoid, you're seeing a little bit of the scalenes there. So that's all functioning for really strenuous breathing in, all right? Needing accessory help that the normal intercostals and diaphragm won't work. What about breathing out? What about expiration? So we're decreasing the volume of our thoracic cavity. So normal expiration does not utilize any muscles. All right? All we do, so if you take a deep breath, all you do is allow the active muscles of active inspiration to relax. So your external intercostals, your diaphragm just relax, the ribs settle down, the diaphragm settles back up again, moves back up. So in its relaxed position, it's high. In its contracted position, it's low. So as it relaxes, it moves back up. The ribs settle back down. All of that functions to decrease the volume of the thoracic cavity. Pressure goes up, and air is pushed out of the lungs. All right? So passive, normal, passive expiration utilizes no muscle. The diaphragm and the external intercostals relax. But what if I'm trying to blow up a balloon? Okay, what if I'm trying to blow a whistle or do something that requires a more forceful activity? Then I can increase the pressure and decrease the volume to push air out. So active expiration, or forceful, does require muscle use beyond allowing the primary inspiratory muscles to relax. And this time we use the internal intercostals. Same set of innervation. And these fibers are in the reverse, all right? So their origin is going to be the lower ribs and their insertion in the upper ribs, and they're going to pull down rather than pull up. We can actually see them just medial to the intercostals, external intercostals. And they're going to depress or lower the ribs. Now what about the opposite? That takes care of our anterior, posterior volume change, all right, to squeeze it back to less than normal volume. What about the superior, inferior, vertical diameter? What do we use to increase that beyond the diaphragm just relaxing? What's the Heimlich maneuver involved? What do you know? Bring your hands together in a fist, go around somebody's waist from the back, and pull them together, that fist, up into the abdominal cavity and up. All right, so you're compressing abdominal pressure, which pushes the diaphragm upward. So without that forceful bruising type of activity, how would we do that normally? Try to blow out hard. What do? Contract and compress your abdominal muscles, which decreases abdominal space and increases abdominal pressure. Now it's going to push down as well, like you were trying to have a bowel movement, but it will also push up, okay? And that helps to increase abdominal pressure on the diaphragm. So we'll just put anterior abdominal wall muscles. So we're talking rectus, abdominis, and our obliques. Increases force on the diaphragm. I was in a bit of a time constraint this morning, so I didn't share with them this story. But I read about a woman back in the 40s, maybe a little earlier. Tuberculosis was rampant in the early 1900s, and they would isolate the individuals, treat them in a sanatorium, give them various treatments and stuff, but remove them from their families to prevent the infection from spreading. And I read the story about this young woman who had developed tuberculosis and was sent away basically to die. And this hospital separated on large grounds and various treatments for the patients, but they didn't think they were going to be able to treat her. She had a large abscess in her lung. One of the treatments that they tried to do to help to isolate tuberculosis creates a wall around itself normally, but it wasn't working on her system. And one of the treatments that they tried to do to help to isolate this infection from the rest of the lung was to inject air into the abdominal cavity and push the diaphragm up against the affected lung and use that to try to compress the area and help to artificially wall off the infection. They tried it with her and it hadn't worked. She was, dying, and so she asked for permission to go home and see her family. And they were reluctant, but it's like, okay, it's her last Christmas at home. So they said, all right, but you have to wear a mask, you don't want to get the rest of your family sick. So she went home, spent Christmas with her family, came back 3 months or so later. The nurses are looking at her. She was pregnant. And they were like, oh my goodness, how could this husband have relations with his wife? And when she's sick and dying, she's not healthy enough to have a child. But they didn't abort it. And as the pregnancy developed and as the fetus grew larger, the fetus did what the air injected into the cavity wasn't able to do. As it rose in the abdominal cavity, the uterus, rising uterus, pushed up on her diaphragm and was able to help treat her tuberculosis by helping it to create the wall around the infection, and she actually recovered.
Wow.
I don't think they started having the women get pregnant as treating tuberculosis, but that over a long period of time, increasing that pressure. And we do it whenever we try to, forcefully blow air into a resistant, non-compliant structure. All right, so let's look now at some of the other factors that affect, well, this is the actual movement. So if we look at page 37, all right, we have, look at how these pressures that we're creating, changes in pressure, are affecting pressure relationships within and outside of the lung itself. So first of all, before we talk further about pressure, I talked about gas concentration. As the concentration of gas increased, a greater number of gas particles occurs, we have an increase in pressure. So we have up here is a higher elevation, all right? This is reference to, could be nitrogen, which is almost 80% of gas, to oxygen, which is 20.9 or so, not quite 21%. Here is the ground, all right? And we see a higher concentration of gas particles close to the ground than we do at higher altitude. Why is that?
Gravity.
Gravity, which means that gas particles have mass. And they do. I mean, it's very minute. It takes a lot of gas particles, different gases, to actually be able to measure it. But all you have to do is move your hand through space, and you can feel resistance. All right? If we were in a vacuum, or we're actually in outer space, and you moved your hand like this, you wouldn't feel anything. All right? So air has a mass. It has a presence. That's what causes sails to fill and windmills to turn. Okay? That does have that mass. So that increases as a relationship of gravity pulling it closer. So if we were to take a basin and fill that basin with mercury and place within that mercury a vacuum tube, meaning no air present in it. I'll get rid of those air particles. The mass of the gas particles being pulled down on the mercury by gravity, all right, it's going to place a pressure on that. And that pressure is going to displace the mercury. In the vacuum tube, there's no resistance. It doesn't have anything in it, no gas particles. So depending on the mass of those gas particles, the number of the gas particles being pulled down, the mercury level will rise up in our vacuum tube. So that's just a real simplistic illustration of when we say that atmospheric pressure at sea level is 760 millimeters of mercury. Now what happens if we take this tray to Death Valley, which is about, I don't know, 23, 27 feet below sea level? Is the line in my vacuum tube going to go up or go down?
Should go up.
It should go up because I'm going to be closer to the center of the earth, a greater force of gravity, more particles are going to be pulled onto the surface of that mercury, and therefore a higher force is going to be created pushing that line of mercury up. And then of course the reverse would be true. If I took it up to 10,000 feet elevation, fewer gas particles, a lower force of gravity at that level, pulling down on the gas, my atmospheric pressure will go down. Okay? Now, sometimes students have difficulty switching back and forth from what atmospheric pressure means or gas pressure means, especially when we start talking about blood gases, arterial blood gases, and venous gas pressure. So if it helps, it's not totally accurate. It's not accurate at all, but the relationship works. So if it helps to think about the number in the gas pressure as actual molecules of gas, and you can visualize that easier. So when I say 760 millimeters of mercury, think about 760 particles of gas within a given volume of air. And 860 millimeters of mercury means 860 millimeters of gas in that same volume, okay? Bouncing around against the size of the airway or against the size of the vessel, or against the size of the blood vessel, if we're talking about that. So that image might be a little bit easier to understand than the just kind of out there vision of gas pressure, whatever that is. So when we look at the lungs, we have them, remember, surrounded by pleural cavity, and the pleural cavity is attached to the diaphragm and to the external intercostal muscles. All right, so we have then our airway extending into the lungs. Therefore, we have a pressure in the lungs. What your textbook calls intrapulmonary, I usually refer to as intraalveolar. Is that a constant pressure? Or is that a changing pressure? Changing pressure. This is what we're changing when we use those inspiratory and expiratory muscles. All right, we're changing, it's the pressure on the balloon. So the intraalveolar pressure is going to be the pressure inside the balloons. So when I expand my thoracic cavity, I can actually hear the air being pulled in. Now, as I do that, why is air moving into the lungs? Because pressure inside those balloons is lower than atmospheric pressure. Now air is moving out of the lungs because pressure in the balloons is higher than outside this container. All right? So we have then, in addition to that, we have our atmospheric pressure. And then we have a third side of pressure in our pleural cavity, which is completely closed. Our intraalveolar space is open to the atmosphere. So there's a connection between those two, a direct airflow, but our intrapleural space is closed. However, it's also affected by the changing volume of the thoracic cavity. So we add this to our system. Intraalveolar pressure. Okay. Now.
I thought that was
No, that's
plural pressure.
Oh, okay. Thank you.
And for the lungs, it says intrapulmonary. Is it
That's the same. It's, I said your textbook usually says, or intrapulmonary, but that would be the same. All right, so on the next page of your lecture notes, you have a diagram that is incomplete, and we're going to work on it together, okay? It's similar to this diagram here. So if we stay at sea level, atmospheric pressure is 760 millimeters. Okay. Intraalveolar pressure, is it always going to be below atmospheric pressure or always above atmospheric pressure or changing? It's going to be changing, all right? So let me put that on in purple. I'll make it black. So notice it's not much of a change. It's no more than I mean, you could make it higher, but generally it's around 1 to 2 millimeters in difference. And so as the thoracic walls, the ribs are elevated and the diaphragm is lowered, pressure in the alveolar sacs will be increased or decreased. Elevate the ribs, lower the diaphragm. Increase the volume.
Decrease the pressure.
Pressure is decreased. So that pressure of the alveoli at that time will be lower. All right? Then we have the diaphragm relaxes and moves up, and the ribs, the external intercostals relax and move down, and pressure in the intraalveolar space increases. So we see this pattern. All right? Now, make it a little higher. When is expiration occurring? As soon as intraalveolar pressure is greater than atmospheric pressure, we have expiration. As soon as intraalveolar pressure is lower than atmospheric pressure, we have inspiration. Now, I'm going to just open my mouth. Okay? I'm not moving any muscles. I'm not contracting or relaxing more. Any muscles, I'm just going to open my mouth. My nasal cavities are already open. Which direction is air flowing? In. Do it. Which way is air flowing?
Nowhere.
Exactly, nowhere. Why? Pressure has equilibrated. So we are at this point right here. Unless you contract or relax muscles more, you're at that point right there where pressure is equal, therefore there's no flow. Okay? To create flow in, I have to lower my diaphragm, raise my ribs, or both. Then I have inspiration. So if I open my mouth, can I breathe in? Yes. But I have to lower my diaphragm and raise my ribs. Can I breathe out? Yes, but I have to compress my abdominal muscles. So just open your mouth without taking a breath and try to breathe out. Feel your muscles start to work? Okay, so you're actually doing active expiration. Because you're just relaxed, air is equilibrated. Now you have to force air out. You're not allowing your muscles, your diaphragm to relax in a greater location. So that shows the relationship between atmospheric pressure and intraalveolar pressure. Now this line down here is intrapleural pressure, all right? So as you contract your diaphragm and relax, the diaphragm is going to move down, the parietal pleura is going to be moving down with it, and intrapleural pressure will move down as well. It's about 4 millimeters difference. It's always lower, however, than intraalveolar pressure. And it's never higher than atmospheric pressure, right? So it never goes greater than atmospheric pressure. So intraalveolar pressure is going to look like this. It's going to be a -4 millimeters in relationship to the intraalveolar. So as this goes up, this goes up. As it, you know, so it follows in place. Unless something happens. So let's say that along the wall here, here's my skin. So along the wall here, I have ribs. And I fracture a rib. Okay? I crash with my bike or forget to wear my seat belt and crash into the steering wheel, or you know, some villain in the middle of the night takes a baseball bat to me or something. And my ribs are broken and they tear into my pleural cavity. Splinter off and break into my pleural cavity. And not just my pleural cavity, my visceral pleura, but my parietal pleura, but my visceral pleura as well. Now, what's going to happen to airflow? As I breathe in, I'm expanding. What happens to my pleural intrapleural pressure when I breathe in? Okay, it also falls, slightly delayed, but it also falls. So air is going to be pulled into the alveoli, but with my visceral pleura not intact, it's going to go through my alveoli out into the pleural cavity. Okay? And then when I breathe out, pressure in my alveoli is going to push air out the atmosphere, but guess what? It's also going to push air into the pleural cavity. And whether I breathe in or I breathe out. Okay? Every time I do that, my pleural cavity increases. And as my pleural cavity volume increases, my lung volume decreases. Kind of like cardiac tamponade with fluid in the pericardial cavity. This can be fluid as well. It's a hemothorax instead of a pneumothorax. So having air in the pleural cavity is identified as a pneumothorax. Okay? And this lung becomes more solid and less capable of expanding. It can also cause the heart to shift to one side or the other and affect cardiac function. Typically, this is treated in the hospital with a chest tube, whether it's fluid or air. A hole is pierced through the chest wall, and the tubing is elevated, usually with a one-way valve. Air rises above, so when you breathe out, that's going to push air from the pleural cavity into this tube, and it'll bubble up into that space. And when you breathe in, and it's pulling on that one-way valve pulls down and doesn't allow the water to be pulled back into the chest tube. So you're actually helping to reinflate your lung each time you breathe out. Okay. Now, there is an incident where about 12 years ago, I keep trying to find the video, but I found a written article, medical article on it, but I haven't been able to find the news story that I saw. It was a young woman from England flew to Singapore for a couple of weeks of vacation. And as things would happen, she met a young man over there and hung around with him. And on the day she was due to return back to England, he took her to the airport. Now, she must not have taken much stuff, a couple bikinis and suntan lotion or something, because he was able to take her back to the airport on his motorcycle. But he crashed. And she was bruised and bleeding, but she picked herself up.